Thank you so much, Dr. Jamuna, for a very lengthy and very comprehensive introduction. Honestly, I was not expecting that, but thanks a lot. That's very kind of you. So a very good morning to you all. I'm currently speaking from a hotel room in Dubai. So it's morning 11 o'clock. I'm not sure what time zones people are joining from, but nevertheless, it's bright and hot summer in Dubai here. So next 30 minutes, I'm going to spend some time on the guidelines for a precision medicine in dyslipidemia. But I thought I'll just to warm up this session, I put a question before you. And the question is, which of the following statements is or are correct? One, all patients above 30 with diabetes should be on statin. Two, calculated cardiovascular risk score above 10% is high risk. Atorvastatin 20 milligram is high intensity statin therapy. Rosuvastatin 20 milligram is high intensity statin therapy. Clinical outcome is not dependent on type and strength of statin you choose. And number 6, you should stop statin therapy immediately as the liver enzymes start to go up. So you may choose your answer in your mind, and perhaps we can discuss this during the question and answer session. So in the next 30 minutes or so, I'm mainly going to concentrate talking on how dyslipidemia increases the cardiovascular risk. How do we choose statin that is based on the individual cardiovascular risk, and some of the practical guidelines that help us to prescribe statins for our patients. We all know that there is a high global prevalence of cardiovascular disease, and it is increasing. And as you will see in the map, the greatest increase has been in the MENA region where I'm currently based. And the next is the South Asia, where my roots are from. And all over the world, there has been increase in the cardiovascular disease since 1990 for the last 3 decades or so. We all know by now that high cholesterol is bad for you, and LDL cholesterol increases the risk of cardiovascular events, including heart attacks and strokes and peripheral vascular disease. And this has been very well established that there is a positive linear relationship between the increase in the LDL levels and the future cardiovascular disease. And we know by now very clearly, and it has been demonstrated by a number of trials, that lower the LDL level, better is the cardiovascular outcome. And this is what you see here on this slide is over the number of years, how the goalpost of the target LDL has changed. If you go back to 1988, the ATP1, the target to control LDL was 130, and now that has come down to 70, even to 50 and 40. So that is the LDL target levels that we are looking at. So we have become more intensive in reducing the LDL level. So that is the target LDL that we are targeting to bring it down as low as possible. So what are the benefits of lowering the LDL level? Now, in the past, what we were targeting, the LDL level was 90 to 130 milligram per deciliter. And this was kind of normal LDL levels for a long period of time. Then we realized through research, and there's now very clear scientific evidence that if you bring down your LDL level to say less than 80 milligram per deciliter, so that is the level that is going to improve the inflammation and the endothelial function in the vascular tree. Now, if you bring down the LDL level further, then that is the threshold level that decreases the atherosclerosis progression. And further reduction of LDL level does lead to primary prevention and also secondary prevention of future cardiovascular events. And we know very well by now that intensive LDL reduction shows a significant improvement in cardiovascular outcomes. As for example, if you lower the LDL cholesterol level, anything between 75 to 100 milligrams per deciliter, the relative reduction in the risk for major cardiovascular event reduces by 44%. If we reduce this further between 50 to 75 milligram per deciliter, the reduction is much greater, 49%. And if you reduce the LDL level further, then this is the cardiovascular event related to this reduction is as high as 56%. And the similar thing that is shown here on the slide, that there's decrease in the mortality, there's significant decrease in the cardiovascular events, both in reduction in myocardial infarction and reduction in stroke. Now, we talked about the lower is better. Now, we also know that earlier is better. So there has been a paradigm shift as to how we target the LDL cholesterol. And lower the better has not changed to earlier and lower the better. So this means that we have got to not only decrease the LDL level to as low as possible, but we have got to decrease it as early as possible. Now, keeping these two things in mind definitely will help for the future prevention of atherosclerotic cardiovascular disease. So lower as well as earlier. So we should not miss the opportunity when we see a patient with high LDL cholesterol, and then we wait and we advise just the lifestyle measures. So in my practice, I give them about 3 months, maximum 6 months. But if the LDL level does not come down, definitely we need to intervene at that point. And that is one, keep it low, start to lower it early, but at the same time, keep it low throughout the rest of the life. Now, these are some of the ways we calculate or assess the cardiovascular risk of a patient or a person. And these are some of the risk calculators. And QRIS3, as you all know, becomes very handy when we look at the patient, and then we are not sure which risk category these patients fall. Now, traditionally, we always prescribe statin, the cholesterol lowering therapy, and there was no clear-cut guidelines as to how we would prescribe. And we would mainly look at the LDL levels or LDL numbers. So we thought that higher the LDL level, so these are the patients we must treat with LDL lowering therapy, including statin. But that has changed a little bit. Yes, LDL level do matter, but what also matters is when we decide to give this statin therapy is what the future cardiovascular risk of that person is. And how the cardiovascular risk assessment helps us. If we know that the cardiovascular risk of a certain individual is high, then definitely we intervene early and we provide the best treatment. And that is not only going to reduce the risk of future cardiovascular event, but it's also going to increase the life expectancy and is also going to improve the quality of life. So there has been a number of guidelines as to how we target the cholesterol, the LDL particularly. But one thing that became more popular in the clinical practice is following the ACC and AHA guideline, American College of Cardiology and American Heart Association, which I'm going to discuss in the next few slides. So this was in 2013, ACC and AHA guidelines, and it made and brought about some clarity as to which patients should be treated with statin therapy or likewise therapy to reduce the LDL levels, and which patients should not be treated. And we have adopted the 4 group of patients that has been discussed in this guideline are the following. And now this was the updated guideline 2018, the ACC and AHA guideline that further classified these patients into different categories, and which would help us to choose the future statin and the lipid lowering therapy. So first category will be the patients who have already got established cardiovascular disease. So if they have suffered myocardial infarction, a stroke, TIA, or suffers from angina, already has got peripheral vascular disease. So this is the group number 1. Group number 2 of patients will be where the LDL cholesterol is more than 190 milligram per deciliter. People or doctors who work with then more than 9. If it is higher than that, are diabetic patients. If the patients are diabetic above the age of 40, and then they are divided according to 2018 guideline by ACC and AHA, that if you have a calculated 10 years risk of future cardiovascular event of more than 7.5%, or it is less than 7.5%. And then the last category are those patients where we calculate, these are for the primary prevention, where the patients have not suffered previous cardiovascular disease, and they are perhaps not diabetic, and the LDL cholesterol levels are not very high. They are between 70 and 189. So what do you do with these patients? So there are different risk calculators. I personally use the QRIS3 risk calculator. You put in some numbers, the age, the ethnic background, the sex, the blood pressure, and so on. And then you come up with a number or a percentage that tells you what is the future risk of that person or a patient for having future cardiovascular event. And if it is more than 7.5%, then you must initiate them on statin therapy. So I've already discussed the first group where these patients have already established cardiovascular disease, and what they need is high intensity statin. Now, what is high intensity? What is moderate intensity? I'll just discuss in my next slide. So the second group, as I said, the patients who are diabetic and whose LDL cholesterol levels are between 70 and 189 milligram per deciliter. So they do not have a very high LDL cholesterol level, but they are again classified into two groups. If we calculate the risk of future risk of cardiovascular event, so they would fall in a category of the moderate risk, where the future risk is less than 7.5% for future cardiovascular event. And then if the future risk for cardiovascular event that has been calculated with the risk calculator is more than 7.5%, then here you have got to use high intensity statin. Now remember, the diabetics are a special group of people, and they are now considered in the group of patients as if they have already suffered a myocardial infarction. So they are very high risk groups, and that's why we have to take care of these patients and start with statin therapy. Now, the LDL cholesterol level is anything between 70 to 189 milligram per deciliter. They do not have established cardiovascular disease. What do we do here? We calculate the 10 years atherosclerotic cardiovascular risk, and then see if it is less than 7.5%, then just advise them lifestyle changes, and there are additional measures to lower the LDL cholesterol and reduce the cardiovascular risk. But if the estimated 10-year risk is more than 7.5%, then you've got to choose either moderate or high intensity statin in these patients. So as I said, that there are three categories of statins: the intensity. So high intensity statin, what does that mean? These are the statins that are going to reduce your LDL cholesterol by at least 50% or more. Moderate intensity statin will reduce your LDL cholesterol anything between 30 to 50%, and low intensity statin will reduce your LDL cholesterol less than 30%. And these are the statins that you can see here on the slide. Say, for example, high intensity statins are two: atorvastatin 80 milligrams or also 40 milligrams, and rosuvastatin 20 milligrams and 40 milligrams. So remember, this is very, very important that once we know the risk of the patients, if the risk of the patient for future cardiovascular event is quite high, then please do not shy away from using the high intensity statin, which are shown here. Either you use atorvastatin 80 milligrams. If you feel that there, for some reason you cannot use 80 milligrams, then at least use 40 milligrams, nothing below that. So please do not prescribe simvastatin 10 milligrams or pravastatin 10 milligrams in these high-risk group patients, because you are not doing any favor. Rather, you will be providing or causing harm to these patients in preventing future cardiovascular events. So very quickly, I'm just going to discuss three cases and just to show you as to how we choose the right statin therapy for a group of patients in our practice. So first case, here is a 62-year-old gentleman, Afro-American male. His total cholesterol is not very high, as you can see here. Blood pressure is normal, not taking any antihypertensive medication, not diabetic, non-smoker. But once you calculated the 10-year risk of future cardiovascular event, it is 9.1%. Now remember, some of these, the risk calculators, they do take into account age, and that kind of changes the future risk. I mean, age is an important factor for predicting a future cardiovascular risk. So nevertheless, so this gentleman's risk for future cardiovascular event is 9.1% for next 10 years. So let's see whether he would require statin therapy or not. So on this tree, as you can see, these are again on the right-hand panel. These are the different groups of patients where they can fall, and we'll see which category he will fall to receive which type of statin. So as we said that he is not diabetic, and his LDL cholesterol is not very high, not definitely less than 190 milligram per deciliter. And this patient does not have established cardiovascular disease. And the risk calculated was, as I said, was 9.8%, was more than 7.5% for future cardiovascular event. So this gentleman is going to receive moderate to high intensity statin. Second case, 50 years old white female, total cholesterol is this time high, and the LDL cholesterol is 139. Blood pressure normal, which is on antihypertensive medication, but at the same time, this patient is diabetic. So it gives you a clue that this patient is already high risk, also a smoker, and the calculated 10-year atherosclerotic cardiovascular risk is 9.8%. So this patient is definitely going to require high intensity statin. So third case is 66-year-old white female. Now this time you see that LDL cholesterol is quite high, but again, less than the cutoff of 189. So the guidelines and the future how you decide for the statin therapy will slightly differ here. Patient is hypertensive and is taking antihypertensive medication, but not diabetic and non-smoker. So somebody who's not diabetic, that does change the equation quite a bit. If the patient is diabetic, then the risk definitely increases. And that helps us to decide by using the risk calculator whether these patients should be on statin therapy or not. Now here the 10-year calculator risk is 2%. And so patient does not have established cardiovascular disease. Patient does not have LDL level of more than 190 milligram per deciliter. And patient is not diabetic, but the calculated risk is 2%. So this patient does not require any statin therapy, but definitely we must advocate the control of the blood pressure and the lifestyle changes to reduce weight and of course reduce the cholesterol number, but just by lifestyle change. So if the LDL is not a target, we all know that the patients may be taking statin therapy, but it is very commonly seen that beyond 1/4 of the population do not have well-controlled LDL levels, which may be because of the inappropriate use, inadequate dosage, or they may not be tolerant to statin therapy. So what do we do next in these situations? So we have other choices, the other medication that we can use or instead or on top of the statin therapy. And these are ezetimibe and PCSK9 inhibitors mainly. So ezetimibe, we all know that primarily it helps in reducing the absorption of cholesterol from the gut. And we may use combining with statin therapy. And the studies have very clearly shown that if you use statin therapy alone and the reduction in LDL cholesterol is not that great, and compared to where you would use ezetimibe combined with statin therapy. So there are no medications which comes in combination where statin is combined with ezetimibe, and it remarkably reduces the LDL cholesterol levels. Now, very quickly, I'll touch upon PCSK9 inhibitors. PCSK9 inhibitors are not new, but they are relatively new medication, but of course costly. They are injectable and they are given subcutaneous injection, and they greatly reduce your LDL cholesterol level up to 50 to 70% of LDL reduction is seen with these medications. Unfortunately, they have to be taken injections, and they are not daily injections. They are given every 2 weeks or every 4 weeks. So very quickly, what it does, we all know that there are some LDL receptors on the hepatocytes, and these are the hepatic cells, and the LDL receptors, they are essentially blocked by the PCSK9. So what happens when these PCSK9, they are special proteins, when they block the LDL receptors cannot be absorbed into these hepatocytes. And what it leads to is there's increase in the LDL cholesterol levels in the plasma or the blood. So LDL cannot be absorbed by the liver cells. That leads to increase in the LDL level in the plasma or the blood. And PCSK9 inhibitor, it inactivates these molecules so that it cannot sit on these LDL receptors, and therefore it helps primarily to increase the absorption of LDL into the hepatocytes, and this leads to decrease in the LDL in the bloodstream. So this is the simplest way I could explain. I hope it is clear to the audience here. And there are now quite a few PCSK9 inhibitors in the market, but this has been traditionally used, the alirocumab and the evolocumab. And there are different way to give as per the FDA recommendation, the maximum dose, as you can see here on the screen. And these are again some of the patient groups where they have been approved for. But remember, these are costly and these are injectable. Now, inclisiran, just very quickly, this inclisiran again is a newer molecule, and it is a gene silencing molecule. And in a very simple words, I can say that they help to reduce the production of PCSK9 in the liver itself. And there have been several studies done with the inclisiran, and this is again, mind you, injectable, but this is given once in 6 months. So first injection is given, and then you give in 3 months, and then every 6 months. And so Orient 10 and Orient 11, these are the two landmark trials that have been studied in inclisiran compared with placebo. And you can see that there was a significant reduction in the outcome future cardiovascular event when you compare to placebo. And there was significant decrease in the LDL cholesterol levels with inclisiran compared to placebo. Now, very quickly, I'll touch upon lipoprotein A. Lipoprotein A again is something that is not very well known, not only to the general public and patient, but also to physicians. So lipoprotein A is a special molecule, and it greatly increases the risk of future cardiovascular event. Now, the prevalence is quite high. 1 in 5 individuals, they do contain high lipoprotein A, which they may or may not be aware of. Therefore, it is very important that lipoprotein A should be looked for, and the individual should be screened for. So which are the individuals who should be screened for lipoprotein A? One, it should be for everybody. At least once in a lifetime, you should check your lipoprotein A. So in the audience, if somebody does not know what his or her lipoprotein A, then I would highly recommend that please get your lipoprotein A checked, because it is an important marker for future cardiovascular event and greatly increases the risk of future cardiovascular event. If there is a strong family history of premature cardiovascular disease, then please check the lipoprotein A. Familial hypercholesterolemia, where we see very high levels of LDL, and we may advocate lifestyle change. It does nothing to reduce LDL level. We may start statin therapy. We may go into the highest dose, and the LDL level may not be, come down to your expectation and as per your desire. So if you encounter this group of patients, then please check lipoprotein A. And if there's already a family history of lipoprotein A, then this patient should be checked for lipoprotein A. By the way, it's called LP little a as well. And if we have initiated patients on statin therapy, and we see that these patients do not respond very well, meaning thereby they may be statin resistant. So these are again the group of patients where Lp(a) or lipoprotein A should be checked. Now, we do not have a very concrete treatment for Lp(a), but these are some of the proposed therapy, and there are some in the still in the research phase. And I hope the number 6, which is the RNA inhibitor antisense therapy, which again injectable, will probably show some light into as to how we can help people or individuals who have got Lp(a) at higher levels that can be reduced. And I'm sure the research is going on in this direction. And in the next coming years, we will be discussing some of the newer therapies that will target especially Lp(a). Now, beyond that, I say that always, and the cholesterol and statin therapy is something that is talked about a lot, and it is talked a lot in the social media. And we all know that there are a lot of things said about, and unfortunately, I feel that statin is the molecule that has received bad name in the 21st century. There are no other molecule where my patients fear to take, but once I mention statin therapy, then they say, doctor, I'm not going to take. And the only reason is that there are a lot of myths that are associated with statin. There are a lot of falsehood and a lot of confusion as well. So what our responsibility as physicians are that we must increase the awareness about cholesterol, about the LDL levels, and how it can impact future cardiovascular event, including cardiovascular death, and how statin therapy and the other related therapies which I talked about should be discussed. And then, of course, the decision, it has to be a decision between the patients and the physician who are prescribing the statin. So it must be very well discussed. So the patients, first of all, understand these very well. They understand the statin therapy. They must understand that they are beneficial for them. And obviously, we do not give them to harm them, but we give them to provide them future cardiovascular benefits. We must discuss that these are the tablets that are not only going to reduce your future risk of heart attack, reduce your future risk of stroke, or reduce the risk of peripheral vascular disease, but may also prevent cardiovascular death. So finally, to finish, these are some of the take-home messages. We all know that dyslipidemia is very well established as an important cardiovascular risk factor, and total cardiovascular risk must be assessed for each patient. So that's why we must look at each patient as an individual, and just looking at their cholesterol level or numbers, not all. We must do the full assessment as to what the cardiovascular risk of that person or patient is. And then based on that, we are going to choose the right type of statin for that patient and in the right dose. That should be based on the cardiovascular risk. And as I said, that we must not forget that patient education and increasing awareness in the public domain, as well as to teach the patients about cholesterol, about the statin therapy, and the other therapies that I've discussed in my talk, should be addressed, and they must be discussed. They should understand the importance of lipid lowering or the LDL lowering therapy. So with that, I thank you very much for your attention. And if there are any questions, I'm open to the floor. Thank you.